Did you know May 17th is World Hypertension Day, in which 10% of all pregnant women are diagnosed with pregnancy-induced hypertension each year? As of 2015, there were nearly 46,900 deaths due to hypertensive disease during pregnancy. Hypertension is more likely to develop in both African American men and women. In this video, we will encourage women to identify risk, effects, and preventative measures associated with hypertension during pregnancy in order to evaluate the risks present in their current lifestyles. We will focus on the types of hypertension seen in pregnant women, particularly gestational hypertension and hypertension associated with preeclampsia. First is gestational hypertension, which is also known as pregnancy-induced hypertension, meaning it only tends to arise when a woman is pregnant. Gestational hypertension starts after 20 weeks of pregnancy and goes away within 12 weeks after birth, usually never harming the baby. Gestational hypertension is classified as the absence of abnormal quantities of protein in the urine. This particular classification differentiates gestational hypertension from preeclampsia, in which 1/3 of women who initially present with gestational hypertension develop preeclampsia. Preeclampsia is defined as having a blood pressure of 140/90 and protein in the urine at or beyond 20 weeks of gestation. Preeclampsia can impair cardiac function for up to a year after birth, despite blood pressure return to normal. One of the features of preeclampsia is multiple organ disease, which tends to complicate around 5% of pregnancies. Lastly is peripartum cardiomyopathy. This disease will be discussed more in depth further in the video, but it is the decline of heart function that tends to occur within 1 month before or 5 months after delivery.
The frequency of cardiovascular disease among pregnant women vary depending on age group, ethnicity, and socioeconomic status. The most common cause of cardiovascular disease for pregnant women or women who have been pregnant is preeclampsia. There are a variety of risks that can cause preeclampsia, which include the mother's history of high blood pressure, if the mother is considered overweight or obese before her pregnancy, and the timing of her pregnancy. While most of these factors can be controlled, there are various aspects that contribute to the risk of preeclampsia. The effects of social determinants of health create disproportionate frequency for African American women and women who live in a lower socioeconomic class. In the United States, African American women are twice more likely to develop preeclampsia and 3 times more likely to have complications during or after their pregnancy that can lead to death. Residential segregation is also a factor because of the increased amount of stress that is related to poverty and other means of living. There is a direct correlation that women who live in a lower income area also have minimal medical resources, which lower their chances of having prenatal care, like yearly checkups or receiving adequate care before, during, or after their pregnancy, which increase their chances of developing hypertension.
Symptoms of gestational hypertension are headache, edema or swelling of the hands and feet, sudden weight gain, nausea, vomiting, pain in the upper right side of the belly, or the production of small amounts of urine. However, pregnant mothers experience different symptoms. Once proteinuria or protein in urine develops, the diagnosis is considered preeclampsia, and the excess proteinuria means the kidneys are not functioning properly. Many women with mild preeclampsia do not feel ill, and the condition is often first detected through blood pressure and urine testing in their doctor's office. Eclampsia is a severe form of preeclampsia that causes the mother to also experience seizures. The escalation of mild to severe eclampsia can progress quickly in pregnant mothers, even within a matter of days. Mothers who have preeclampsia can experience permanent damage to their organs. They can also experience fluid in the lungs. Studies show women with preeclampsia are 4 times more likely later in life to develop hypertension and twice as likely to develop ischemic heart disease compared to women without preeclampsia. Peripartum cardiomyopathy affects 1 in 3,000 pregnancies and is more common in women of African descent. Peripartum cardiomyopathy is usually defined as having a left ventricular ejection fraction of less than 45% and occurs within 1 month before or 5 months after delivery. Symptoms include fatigue, heart palpitations, nocturia, shortness of breath with activity, and when lying flat, swelling of the ankles, swollen neck veins, or low blood pressure.
Now, you're probably asking, what does this mean for my baby? And that's a great question. Along with the numerous effects on the mother, the baby is predisposed to a variety of complications as well. While peripartum cardiomyopathy does not have an effect on the baby due to its development in the mother after delivery, gestational hypertension and preeclampsia can both result in similar complications within the unborn child, the most common being smaller weight at birth. Both can compromise blood flow between the fetus and placenta, which in turn reduces the amount of nutrients given to the fetus and contributes to its smaller size. This condition, known as intrauterine growth restriction, can cause the infant to be smaller than 90% of other newborns. Intrauterine growth restriction can decrease the ability of the infant to fight off infection and increases the chances of infant mortality. The risk of this is much higher with exposure to preeclampsia than gestational hypertension, and the need to deliver early in order to prevent the progression of preeclampsia also contributes to smaller birth weight. Preeclampsia has been linked to a number of additional complications within the fetus. With preeclampsia, the production of new blood vessels can be compromised. This leads to abnormal development of the lungs and requires the infant to have long-term oxygen treatment after delivery. This condition is known as bronchopulmonary dysplasia, which can give rise to other respiratory issues later on in life. While more research is being done, there is speculation that preeclampsia is also linked to delays in neurodevelopment. Additionally, infants with preeclamptic mothers have higher risk of developing obesity, diabetes, and a number of other cardiovascular diseases as an adult. The extent of these adverse effects on the baby directly depend on the severity of preeclampsia within the mother. Findings from a 2014 study has shown that not only are African American women more likely to experience hypertension during pregnancy, but they were also much more likely to experience severe cases of preeclampsia when compared to white women. This is in contrast with Asian Pacific Islander and Hispanic mothers, who are actually less likely to develop severe preeclampsia or hypertension in general when compared to white mothers. In other words, Black mothers are more likely to develop severe preeclampsia than any other group, meaning that their children are more likely to experience the adverse effects of preeclampsia to a greater extent. Researchers speculate that this may be tied to the fact that African American women are more likely to develop cardiovascular disease than any other group, in addition to possible socioeconomic factors such as education and income.
So, how can you lower your risk of developing and assist in managing your hypertension? If you're thinking about becoming pregnant and you currently have a hypertensive disorder, you can talk to your doctor about coming off any ACE inhibitors or ARBs that you may be taking. These medications have shown to cause a threefold risk in birth defects if taken while pregnant. There are many drugs used to lower blood pressure. A single oral agent is usually effective enough, but sometimes an intravenous agent is recommended. The majority of women with controlled chronic hypertension under appropriate management will have successful outcomes. Management of blood pressure can also be complicated during breastfeeding. Speak with your physician about medication to use during this time as well. How can you lower your risk of developing and assist in managing your hypertension? Prior to and during pregnancy, it's important that you take the necessary steps to keep your blood pressure in normal range. Recent guidelines from the American Heart Association encourage women with chronic hypertension to keep their dietary sodium intake low, either by reducing or substituting sodium salt before pregnancy. Smoking and alcohol consumption should also be withdrawn. It is also recommended to encourage and maintain a healthy body weight. Maintaining high levels of potassium intake can help to antagonize the effects of sodium and in turn also lower your blood pressure.